we'll talk about the important ones. طيب نبدأ بالدefinition. What's the definition of altered level of consciousness? أنا بجلس أتقهوى وانتظركم تجاوبون أو واحد يرفع يده يجاوب. ما زلت بانتظار أي أحد يجاوب على what's the definition of altered level of consciousness.
Sudden or gradual change in behavior.
ممتاز. طيب في sudden أو gradual. ممتاز. ففي bottom line is that there is a change in behavior. ممتاز. طيب what else؟ يعني if I'm at 1 minute I'm acting normally and then at the other minute I'm not acting normally, that's a sudden or gradual change in behavior. What else goes under the definition of an altered level of consciousness? ممتاز. Patients confused. ففي change in behavior أو في confusion. What else? What about the response يا ريان? What happens to the response? يعني قلنا الحين إنه في change in behavior, في confusion أو في change in response. But what about specifically the change in response? What happens to it? So decreased response to stimuli. ممتاز. طيب. فهي defined as impairment of arousal اللي هي زي ما قال ريان اللي هي decreased response. You can't arouse a patient. Impairment of cognition means that the patient has a confused status or change in the patient's behavior. يعني if the patient or the person is acting normal or they're normal for a certain number of years and then they have a gradual change in that norm or a sudden change in that norm, that's defined as a altered level of consciousness. طيب. Is there anything else that may fit under these? يعني في medical diagnosis that we commonly use, especially for the elderly, that can be fitting into one of these definitions that has a specific name. Do we know what it is? ممتاز. شكرا. delirium. ترى هذا النظام اللي بتاخذه بقعد ساكت لما تجاوبون وعلى حسب متى تجاوبون انتم هو اللي يحدد متى نمشي. فالdelirium is one of the things that we commonly use as a diagnosis for the elderly that is basically a disturbance of their consciousness يعني سواء their awareness level of awareness ولا attention أو عندهم an impaired cognition أو perception, meaning that they seem confused زي ما قلنا. It's typically of acute onset and is fluctuating, meaning it comes and goes. It's not constant for a number of years or days. It comes and goes. And is either caused by a general medical condition, a substance, or multiple factors at the same time. Why is this important to know? Because a lot of the elderly patients are the ones who actually present to the emergency department with an altered level of consciousness, and we need to diagnose. What's another important thing to know about delirium? The other important thing to know about delirium is أحد يقول. طيب احنا قلنا one of the important things is that it's acute onset which is fluctuating. What's the other important thing to know about delirium?
Doctor, could be repetitive.
ما فهمت. وضح لي
تكون
أكثر.
متكررة يعني أكثر من مرة.
He delirium is by definition it's fluctuating and it comes and goes. It comes and goes. فهذا عرفناه. هذا one of the things in that acute onset it's fluctuating. It comes and goes. But what's the other important thing that we have to know about delirium? Is delirium a diagnosis?
Maybe any medical condition because
Yeah, so زي ما قال عبد الرحمن الحربي it indicates a serious illness potentially, yes. أو زي ما قلت أنت ما أدري مين أنت بس آخر واحد تكلم قال إنه مصعب إنه في something going on. فمعناها it's not a diagnosis on its own. حتى زي ما جاوب راكان it's not a diagnosis on its own. It's caused by something else. فما يجي واحد وأقول له what's the diagnosis وتقول لي delirium. Delirium indicates that there's a cause underneath that symptom or medical status that the patient's in. They're not in their right mind, but they're not in their right mind. We've labeled them with delirium, but they have to have another diagnosis. What's the most common diagnosis causing delirium in older patients?
glucose.
Most common cause is not glucose. لا. It indicates a shock. لا, it doesn't indicate a shock. It doesn't necessarily indicate DKA. DKA is not the most common cause. Polypharmacy may be a cause, but it's definitely a cause, but it's not the most common cause. Infection, what specific type of infection? Yeah, Abdurrahman. UTI, absolutely. So UTI is the most common cause of delirium in the elderly patients. So these are things to keep in mind. All of the ones that you've mentioned can cause delirium. So DKA, shock, whether it's caused from sepsis or hypovolemia or anemia or whatever it is. Polypharmacy, so multiple medications, especially if using narcotic medications in the elderly, and infection, but the most common cause is a UTI in the elderly. So they present like they're having a stroke, they present like they're having some serious intracranial process that's going on, but can be due to a simple with antibiotics. طيب. What's consciousness? Consciousness is the state of full awareness of one to themselves. So they're aware of themselves and one's relationship to the environment surrounding them. That's the consciousness. So what's component of consciousness? زي ما تكلمنا تو. Arousal, meaning the degree of necessary sensory stimulation to keep the patient awake. One patient who is awake or one person who's awake on their own, just sleeps, wakes up, is fully awake, is different than one who requires painful stimuli to wake them up or to get them aroused. And then also different from one who requires people to talk to them constantly to keep them awake. And these arousal and sensory stimulation, even motor stimulation, is things to consider also in the Glasgow Coma Scale, which I'm assuming I gave you guys the trauma talk. So GCS is when we measure these. Content. So what has cognition and the affective components of consciousness. So cognitive is how the patient actually speaks to you. So they may be awake, they don't need any arousal, but they have a cognitive impairment. So they can't speak properly because they're confused. They have زي ما تشوفون في psychiatric patients مثلا word salad أو flight of ideas أو pressured speech. They may not recognize faces, they're confused, so they don't recognize their children, their mothers, their friends, whatever the case may be. They have an inappropriate awareness of space around them. These are all components of cognition. Affective is the appropriate level of affect. So are they unnecessarily aggressive? Do they have a flat affect, meaning that they you actually talk to them about something that's very upsetting, and then they have no affect towards it? This is what we call a flat affect. Are they generally toned down? They don't have any issues with their arousal. They're awake. They don't have any issues with their cognition, so they have normal speech. They have normal face recognition. They're aware of the space around them, but they don't have the appropriate affect in response to whatever information that they're being given. These are all important components of consciousness. طيب. What makes the diagnosis of the altered mental status patient difficult? Meaning we just decided, or we just agreed that the actual altered mental status patient has a cause to what's going on. What makes this difficult for us as physicians in the emergency department in terms of finding what the cause is? What are the important components of this? Okay, so the first thing is that there are many. So we have a diagnostic challenge. Number one is that there are many causes that can lead to this. What else? ما ادري وشو يا عادل قصدك انه ما في فحوصات دقيقه بس medical terminology. طيب عبد الرحمن, I don't know what you mean by Glasgow score. في Glasgow coma scale, but this doesn't make the diagnosis difficult unless you're talking about the patient. Interventions are difficult regarding the cause. طيب, you have to find out what the cause is. I'm not talking about different interventions now. أنا قاعد أتكلم إنه how do we find what makes the altered mental status patient or the altered level of consciousness patient a diagnostic challenge? What makes it difficult to actually find the cause of their condition or their altered mental status? So we're not talking about interventions. Specific investigations, if the patient's in a coma. طيب, ممتاز. So if the patient's in a coma or is in altered, so we have the patient factor, which makes it difficult to actually pinpoint what the problem is because the patient who has the issue is unable to talk to you. What else? Absolutely. So taking a history from the patient, if you can, when they're altered, it may be difficult. What else? أنا ماخذ معكم أسلوب جديد عشانها سيشن وليست محاضرة. فمن أول كنت أسلك إذا ما حد يعني ما you're not interactive. الحين أنا عندي 3 ساعات وبطلعها من عيونكم. فإذا ما أنتم مجاوبين بنقعد عادي معاي كوب قهوة وقاعدة قهوة ومبسوط لما تجاوبون. ممتاز. So another component is if the patient's new to your department. So you don't have patient data. Oh, the patient's data is old. They last came to your department 15, 20, 30 years ago. You have no records. Presence of another disease. I'm not sure what that means, but يعني I'm assuming you mean that they may have comorbidities ongoing at the same time, so it makes it difficult. Okay, I'll count that. What else? ما شاء الله تبارك الله. I'm not moving on until you actually give me some answers. أبيكم تشغلوني أقولكم. تجلطني يا عبد الله. ما فهمت السؤال اللي أنا ساعتين نتكلم فيه. أقول لك what makes it, what are the factors that make it difficult for you to actually come with a diagnosis of the cause of the altered mental status of a patient who present with an altered mental status to your emergency department. يلا. قلنا احنا من ضمن الفاكتورز ان مثلا يكون البيشنت in a coma, so you can't talk to the patient. The patient has no ability to give you a history, which is kind of falls under the umbrella of a patient's decreased level of consciousness, مو بس altered. The patient has no history at your hospital, so you're unable to access their chart. ما تفرق الage of the patient لأن لو جاك young و altered ولا old و altered, it's still the same difficulty in terms of finding the cause. طبعا each age category has their own causes, but it's still difficult to find the cause. اي قلناها اذا كان باست داتا غير موجوده في المستشفى. طيب هذه بنمشيها لكم هذه المره فقط، لانه واضح انكم تنحين. الدايجنوستيك تشالنج اول شيء قلنا البيشنت فاكتورز اللي هي ذكرناها. البيشنت has no ability to give you a history because they have decreased level of consciousness. The patient is unable to talk to you. The patient doesn't have prior visit to your hospital, so you can't actually see the prior medical issues. The caregiver. So if the caregiver أو الambulance personnel اللي هو paramedics وال EMTs that bring the hospital bring the patient to your hospital don't have the ability to give you a history because they have مثلا a frustration with the patient's status. Let's say if they're elderly and they have a difficulty with approaching the patient, they have a difficulty to provide care to the patient, they have frustration. في بعض العوائل اللي تصير عندها خصوصا عندنا مجتمعاتنا they're apprehensive meaning انهم يصيرون دفاعيين على what the causes may be, they may try to make things a little bit more difficult for you. A diagnosis and treatment, it makes it difficult زي ما قلتوا انتم انه ما في specific things that you can do that give you the answer right away. So especially when it's a patient who is unable to talk and the family is unhelpful, the diagnosis and treatment is delayed. So these are the factors that make things difficult for the diagnosis of the cause of an altered mental status in a patient, whether younger or old. طيب, we'll start with the case. 75-year-old female who was found down at home. She was brought in by emergency medical services. They're moving her on the stretcher now while you're there in the emergency department. Do you have any history? EMS personnel says, I have nothing for you. I found this patient down at home and we brought them. That's it. Someone called. الخدامة كلمت وقالت the patient is down وكلمت 911 وجو أخذوها. That's it. Are you able to get to review systems? You're not able to get to review systems. Do you have any past medical history? You have absolutely no past medical history. EMS personnel have no information. There is no family members. The patient's first visit to your emergency department or your hospital. So if you choose emergency medicine, this is going to be something that you see on a frequent basis. So what could this be? It could be absolutely anything. What can help you find the diagnosis? Things we've mentioned before. An older patient could be affected by a simple UTI, such as this one. A younger patient could be having something more significant going on. So emergency medical personnel, family members, previous files at your hospital, the vital signs, the physical examination, the labs and the imaging are all the things that are going to help you find the cause. طيب, how do we approach any patient who comes in? Do we just do everything for them? No, absolutely not. So we have to categorize the patient based on age, based on what information we have from people around, such as this case, we have nothing. We see what we have in terms of previous medical files. So if the patient has multiple, let's say, UTIs in the past, then this may be a UTI again. So it can help me pinpoint a little bit towards that in terms of investigations. And then my physical examination can tell me a lot. So let's say I examined this patient and I see that the vital signs show that she's tachycardic, hypotensive, and she has a sore on her back that looks infected. What's the working diagnosis going to be? جزاك الله خير باسل. ايه infection, لكن infection, what's the infectious process that's going on? So the patient, I said, on examinations, tachycardic, hypotensive, has a lower back sore. This is just based on the examination. We've done nothing yet. What is our working diagnosis in a patient who comes with an altered level of consciousness, has tachycardia, has hypotension, has a sore on her back? Yes, septic shock. Septic shock secondary to what? Well, we don't know if this is bacteremia or not. I'm telling you guys, she has an infected sore on her back. So this is going to be an infected wound. So it's going to be an open sore on the back that's infected. That's going to be our working diagnosis. So we can pinpoint our workup as that to be a working diagnosis. But is this an appropriate approach to someone who presents with an altered level of consciousness? Absolutely not, because we, one, know that the causes are so many, which we'll talk about in a little bit. And another thing is that we may have more than one process going on at the same time. تمام? فalways keep these things in mind. What are potential causes? أبغى أسمع واحد that is an absolute must not miss in any age group and a patient presenting with an altered mental status. What do we do for these patients? Absolutely. Thank you very much. We have to do a gluco check because this is an absolute no miss. So I just had this case 5 days ago, I think on November 11th, on November 4th. A patient came in with his family, middle-aged man. They bring him in on a wheelchair. He's altered, he's confused. He's actually doing these weird movements with his upper extremities and lower extremities. You talk to him, he's just doing his weird movements with his mouth. He's not responding to anything you say. The first thing we asked for was a glucose check. His glucose was 0.5. It was at a dangerously low level. All we had to do was give him D50 and he was fine. Now the question is anyone who comes in with hypoglycemia, is that the only diagnosis? Absolutely. You have to consider another diagnosis. So no. ليش؟ لأن this patient, once we gave him his D50, he became alert. We were able to talk to him. And then he was saying, I feel fine now. But when we talk to him and take his history, he tells us that he has ischemic heart disease with a prior cabbage. He has chronic kidney disease and is actually on dialysis. He has diabetes, hypertension, hypercholesterolemia, and is a smoker. So we talked to him further about that day and we asked him what happened. He said, I don't remember anything. I just remember being at home and now I'm in the hospital. I didn't feel well and now I feel great. I feel my normal self. Is that enough? Absolutely not. الحمد لله أن كنا مصحصحين وتكلمنا مع الفاميلي وقلنا لهم وش اللي حصل. الفاميلي قالت أنه the patient was complaining of chest pain and then he had this situation. So we directed our workup as a potential cause for his hypoglycemia as increased stress. Increased stress doesn't necessarily mean in the brain only. It can be on the body that can cause hypoglycemia. You've had increased glucose consumption. What caused his increased glucose consumption? This particular patient, he had an MI, so he had an NSTEMI. We did an EKG for him that was normal. We did a troponin that was 1500, 1500. So he had an NSTEMI, he was admitted to the CCU. If you don't keep these things in mind, it would be extremely easy that a patient comes in with hypoglycemia with no clear cause. You treat the hypoglycemia and you send them home because the patient says, I feel fine. And then they die from a cardiac arrhythmia while sleeping at home that same night. تمام. This is why you always consider other diagnoses in your differential. Always. We have a question. Can low or high sodium levels cause it? Absolutely. It's more common with hypernatremia, so higher levels of sodium, because the shift causes the brain to swell, which causes your altered mental status. طيب, what are the potential causes? It can be remembered in this mnemonic, which is called move stupid. So what does move stupid stand for? We'll go over each of these one by one. The first one is M, which is metabolic. So what are the biggest ones in metabolic? Like we mentioned, glucose, so hypo or hyperglycemia. So if the patient comes in and DKA, they may have issues with an altered mental status, especially if it's significantly elevated. Because what happens with DKA? hypoglycemia. شكرا. إذا أنت تظن يا شيخ محمد أن hypoglycemia happens with DKA فهذه مشكلة. لكن what happens? So hyperglycemia. Okay, but what's the issue? What's the issue with this that may lead to an altered mental status?
Metabolic acidosis, respiratory alkalosis.
Absolutely. Yes. So you have a metabolic acidosis. If the patient has a severe enough acidosis, you can have an altered mental status. What else can cause this? You have, with diabetic ketoacidosis, you have significant potassium and sodium shifts. So you have to make sure that the potassium and sodium levels are fine, which can lead to the DKA leading to an altered mental status. Serotonin syndrome, I won't get into the details of. It's a syndrome that can lead to an altered mental status and cause these symptoms. What are the symptoms that happen with اللي هو glucose metabolism issues, mainly hypoglycemia? You can have increased heart rate. What else? Sweating. What else? Blurred vision, absolutely. And then you can have myoclonus, which is the movements that I was talking about with the patient that presented to my emergency department. You can have hyperreflexia. So the patient has his reflexes basically are exaggerated. And then you can have tachycardia. Okay, good. طيب. O. So O is for oxygen. So what happens if the patient's hypoxic?
Increase respiratory rate.
So absolutely increase the respiratory rate. But we're talking about a patient with hypoxemia and an altered mental status. What happens? How do I differentiate?
Oxygen saturation.
كيف?
Oxygen saturation.
Yeah, we check the oxygen saturation, absolutely. So this is why it's an important thing for every person to get vital signs and the proper examination and the thorough history. But the question is, how do I differentiate? If I know, يعني أنا أقول لك الحين عندك patient with altered mental status. وما أعطيك more information than this وأقول لك it's due to oxygen. How do I differentiate between a hypoxic patient or a hypercapnic patient? How do I differentiate between these two? Based on examination only. So a hypoxic patient may have cyanosis, ممكن. Breathing fast or slow, ممكن. So typically hypoxic patients are breathing faster and hypercapnic patients are breathing slower. What else? So what's the difference between these two in terms of mental status? واضح إنه بنطول على O. They both have an altered mental status. What's the difference between these two? What's the difference between hypoxic or hypercapnic in their mental status? لا ما نفيدك فيها يا دكتور، تفيدنا أنت إن شاء الله فيها. أنا قلت لك اليوم إن شاء الله بخلص القهوة اللي في البيت كلها، مخمخ عليكم هنا.
واحد يكون متوتر يا دكتور والثاني هادي.
ممتاز. مين اللي يكون متوتر ومين اللي يكون هادي؟
الهايبر يكون متوتر والثاني هادي.
خطأ. A hypoxic patient is usually agitated. Just to help you remember this, always think about the patients who come in who are having difficulty breathing secondary to مثلا a severe asthma exacerbation. What happens to them? They come in severely agitated. They're gasping for air. They can't sit still. They're tripoding on the stretcher or on the chair. They want you to help them quickly because they feel like they can't get enough air. So they want someone to actually help them. It's like a choking patient. They need help. These are the ones who are agitated. So hypoxic patients are typically agitated. Hypercapnic patients typically have elevated CO2 levels, which makes their their level of consciousness decrease. So they're sleepy. So that's the difference between these two. Okay, so whenever you have an agitated patient, make sure that when you get vital signs, you make sure that their oxygen saturation levels are okay. And then if you're still concerned about them having a hypoxia, even though their oxygen saturations are well, what can you do? لا in terms of diagnosis ما أبغى treatment. أكيد the hypoxic patient بتعطي oxygen. But what's the treatment? How do I diagnose? يعني what the potential causes of patients who have a normal saturation but are actually hypoxic? Absolutely, you do an ABG. وأحيانا you have to do a meth hemoglobin levels just to make sure that they don't have methemoglobinemia, because they can have normal O2 saturations on the pulse ox, but they're actually hypoxic, and that's what's causing their symptoms. Okay, CO2 levels, we do them for the hypercapnic patients, which can also be seen on an ABG or VBG. طيب, vascular causes. What are vascular causes of an altered mental status? Stroke, good. So ischemic stroke, yes. Hypertension, so hypertensive emergency. طيب, أنت يا عبد الله, بما أنك قلت hypertension, how does hypertension or hypertensive urgency/emergency cause an altered mental status? Still waiting. How does a hypertension close, so it leads to vasoconstriction, which can lead to reduced perfusion? Yes. So the whole mechanism of aslan vascular causes of altered mental status are secondary to decreased brain perfusion. But specifically hypertensive urgency or emergency leads to brain edema. And then when you have brain edema, we've talked about this in the trauma talk, you have increased volume in the same space, so you have less perfusion. تمام? This is what causes the symptoms. What other vascular causes can lead to an altered mental status or altered level of consciousness? MI, perfect, excellent. Okay, so MI can lead to decreased perfusion and lead to an altered mental status. طيب, الحين عندنا الإي, طبعا أنتم الحين عارفين إن إحنا move, so E is the last letter of the first word. M قلنا metabolic. O قلنا oxygen. V is vascular. E is electrolytes or endocrine. What are some of the causes of electrolyte endocrine abnormalities that can cause an altered mental status? We've mentioned one important one, which is hypoglycemia, that can be in the metabolic issue. And then we've mentioned that hypernatremia can cause global mental suppression through swelling. What else? One more that's important, and then we can move on to the remainder. خليكم ساكتين وانا بنتظر. ولا تدرون هذه صعبة شوي؟ ممتاز. هايبر كالسيميا كنت بقول صعبة شوي. Resume share. So hypercalcemia is another important one that can cause global mental status suppression or mental suppression. Electrolyte imbalances عموما لما تصير rapid but with specific attention to hypernatremia and hypercalcemia can lead to global mental suppression. طيب, S is seizures. So seizures can be an active seizure. It can be status epilepticus, which is an ongoing seizure for more than 5 minutes or more than one seizure without returning to baseline. Or the patient can be in a post-ictal state. So these are things to consider when dealing with a patient with an altered mental status. Did they have a seizure? And if they did have a seizure and they are actively seizing or have a post-ictal state, what's the cause of their seizure? Did they fall and hit their head and have an intracranial bleed? Did they not take their medication for their epilepsy? Do they have cancer and now it's metastasized to their brain? So we have to keep these into consideration when dealing with a seizure patient. T, you have the trauma, tumor, temperature, and toxin. We've talked about trauma before extensively, so I won't get into details with that. But the bottom line is you don't necessarily need a patient to be in a coma only secondary to a bleed. So if you do a CT scan of their head post-trauma and they don't have a bleed, they can still have something we've talked about in the trauma talk, which is diffuse axonal injury, which is something you don't see on imaging, especially not early, and they can be in a coma for a period of time before returning to baseline. Tumor, it depends on where the tumor is and if it's large or small and if it's causing any pressure or not, or if it led to a seizure or not, whether it's a primary tumor or metastases and so on. How does hypothermia lead to an altered mental status? ما زلت بالانتظار.
معليش دكتور ممكن تعيد السؤال؟
السؤال is how does temperature affect mental status?
organs dysfunction.
كيف؟
organs dysfunction.
يعني أكيد بيصير في عندك altered mental status معناها في organ dysfunction, بس we need to be specific. How does temperature lead to an altered mental status?
معليش يا دكتور بجاوب جواب عام، يعني انه ممكن اللي في الغالب اللي نشوفه مسخن ولا شيء يكون جدا هادي وعصبي في نفس الوقت، يعني من نظرة خارج الطب شيء زي كذا بهذه الطريقة.
احنا قاعدين نتكلم عن approach to altered level of consciousness في ما ادري معطيني level 11 medicine، فانا ما ابغى نظرة عامة خارج الطب، انا ابغى a medical answer to a medical question. How does temperature affect the mental status? How does it lead to an altered mental status? قلت لكم انا جايكم مروق اليوم، مروق وفاضي. عادل ان عاد قلت لي افدنا فيها بطلعك برا المحاضرة. هو انت اللي قلت لي افدنا فيها قبل ولا لا؟ ما في افادات، انتم اللي بتفيدوني. طيب ممتاز، حلو. heat stroke هذه one way, so you can have direct effect of elevated temperature on the actual mental status or level of consciousness of a patient. That's one way. Dehydration is not يعني ممكن. طيب ممكن طيب think outside the box. Think outside the box for يعني مو بكل temperature is elevated صح؟ So we have heat stroke, we have a patient who comes in with an altered mental status secondary to an elevated temperature causing زي ما قال واحد multi-organ damage ممكن. So if you have multi-organ damage, meaning a patient comes in and let's say septic shock and they're febrile, and this septic shock is secondary to bacteremia from one source or the other, and then they have acute kidney injury, and then they have elevated BUN, and then they have elevated creatinine, which leads to the next thing we'll talk about, which is uremia. That can lead to an altered mental status. But if the temperature is low, which is something you have to think about, because the patient's temperature is low, as you know, the SIRS criteria is if the patient's temperature is 38 or above or less than 36. So you have to think about low temperatures. I did training outside of Saudi, so we used to see hypothermic patients all the time. How does the hypothermia affect the mental status? يصير في global depression of the ion channels. And if you have suppression of ion channels, you have basically suppression of the neurological function of neurons themselves. And if you have a neurological dysfunction of neurons, then you have a dysfunction of your altered mental status. تمام. طيب what are some of the toxins that can lead to an altered mental status, whether decreased or agitated? We talked about one, which is carbon monoxide, but what else? So carbon monoxide can lead to hypoxemia, can lead to an agitated patient or altered mental status patient. But what are two other major ones that we need to keep in the back of our mind when dealing with an altered mental status patient that may be a cause in terms of toxins? We don't see them often, but we still need to know them, especially for يعني ممكن potential exams. لا, I'm not talking about drugs. لسه ما دخلنا في drugs. Toxins. طيب هذه صعبة عليكم شوي فبقول لكم إياها. في mercury and lead. شكرا يا نوح. Yes, lead poisoning can lead to an altered mental status. So احنا قلنا mnemonic is move stupid. It's funny, I think. يعني it's not, maybe not funny, but at least it helps you remember it. And U is uremia. So urea elevation can lead to an altered mental status. Another thing that you need to remember in terms of uremia is you can have kidney failure, which leads to uremia. You can have liver failure, which leads to what? Hi, Ikhwan. How does liver failure affect your mental status or your level of consciousness?
relaxation.
ما سمعت. ما سمعت الجواب. شكرا. عبد الرحمن by removing toxins. شكرا لانك علمتنا وش قاعده تسوي الكبد. removing toxins. I need the answer. So yes, the answer is وائل ومحمد. شكرا. اللي هو hepatic encephalopathy. So what happens in hepatic encephalopathy? You have elevated levels of ammonia. Elevated levels of ammonia can lead to an altered mental status. How do you diagnose hepatic encephalopathy? If it's suspected in a patient, typically in those with cirrhosis or hepatitis or known liver cancer, liver failure, typically they'll present with an altered mental status. And then once you do an ammonia level, you'll find it to be elevated. It's more of a clinical diagnosis that's confirmed with an ammonia level. حلو. طيب, P, psychiatric. So what are some of the psychiatric diagnoses that can actually give you an altered mental status? هذا ممكن اسهل سؤال اليوم، فقاعدين تفاجئوني انتم. Psychiatric diagnoses that have an altered mental status. يعني اسهل من كذا ما في. شكرا. Mania is one. What else? Depression may be one if they have a flat effect. What else? So catatonia is, schizophrenia. As a part of a treatment for schizophrenia is you give medications. Some of them can cause catatonia. These are typically all basically given benzos that help them relax, and then typically they get better. يلا باقي حرف بعدها. Infection. What are some of the infections that can cause an altered mental status؟ واللي بيقول لي sepsis ولا septic shock ولا مدري وشو، يعني خلاص خلصناها، قلناها مليون مرة قبل. What specific infections can give you an altered mental status or a decrease? Meningitis. شكرا. So meningitis, encephalitis, cerebritis, all of the infectious processes that go on in the brain can lead to an altered mental status or a decreased mental status. Now we get into drugs. طبعا this is by no means a commercial or an invitation to do drugs. This is actually supposed to be quite the opposite. If you want to lose your teeth and look like these guys, then by all means do drugs, otherwise stay away. How do we diagnose drugs? We diagnose drugs intoxications that lead to an altered mental status. It's typically in all age groups it can happen. So it can happen in the young who are otherwise healthy, who are found down in a quote unquote party. يقول لك والله كانوا طبيعيين بعدين فجأة صار كذا. It can be alcohol that can have a decreased mental status. We see alcohol a lot more nowadays than we did before. So alcohol intoxication, it can be a hallucinogen. So it can be something مثلا glue sniffing. They can take benzos, they can take cocaine, they can take PCP. All the drugs can lead to an altered mental status. Typically, if someone comes in who's young, otherwise healthy, it's an illicit drug use. If it's an elderly patient, then it can be, let's say, an overdose, an accidental overdose of medications that they take. So it was mentioned earlier, polypharmacy. And another thing is that if they take more than their dose of, let's say, a beta blocker, then they may have bradycardia, which leads to decreased perfusion of their brain, so they have an altered mental status. Another cause may be that they have كانت في مخي وراحت. هذا كله من العصبية عليكم تو. Other drugs in elderly patients, they can take their normal medications and have this, and the narcotic medication. So this is why we limit, this is the one that I wanted to say, this is why we limit giving narcotic medications in elderly patients, because it can lead to, even in small doses, and not necessarily a decreased level of consciousness, but can cause an altered level of consciousness. So they can be very confused, they can be severely affected by small doses of narcotic medications. So the bottom line for things to remember for an altered mental status or altered level of consciousness is that, one, it can affect both hemispheres. So you have a global depression of both hemispheres, whether it's because of a seizure, so it increases the neuron activity to a point where it's not maintained well by the brain. It can be a global depression of both hemispheres because of poor perfusion, and we've discussed the list of things that can cause, whether it's hypoxia, whether it's high CO2, whether it's decreased temperature that leads to global suppression of the ion channels, whether it's a drug that affects the whole brain, whether it's meningitis, or it's a reticular activating system, which depends on what's affecting that. So it could be a stroke, it could be trauma to the reticular activating system that leads to the altered mental status. الحين الساعة 2:15. We'll take a break إلى 2:30 بالضبط, and then we'll come back and continue. We're over halfway through, and then we'll talk about the approach. We'll go back to the case that we presented earlier, and we'll see how we do then. Okay. So 15 minutes, 14 minutes to be exact. We'll be back at 2:30 exactly, and I'll start whether you guys are here or not. Any questions before we go to break? اوكي، الوعد الساعة 2:30 بالضبط. يلا إن شاء الله جاهزين لمزيد من الاستقعاد. يبدو لي خسرنا كم واحد، صرتوا 25 الحين، بس بكيفهم. بسم الله. طيب الابروتش، نبغى نتكلم عن الابروتش للبيشنت with an altered mental status او altered level of consciousness. طبعا يعني الجنرال ابروتش في some basic things that you have to do وفي things that are specific towards potential diagnoses. So tell me, what do we do in case of a patient who comes into your emergency department with an altered level of consciousness? ممتاز. So ABCs. What else? check glucose. excellent. هذه دائما حطوها في بالكم اذا بتطلعون يعني باشياء بسيطه من المحاضره هذه. just remember ان anyone who comes in with an altered mental status, decreased level of consciousness, any neurological symptom, يعني يقول لك weakness, numbness, difficulty with speech, difficulty with حتى لو you're suspecting stroke, حتى لو it is a stroke, please always check the glucose. طيب, so قلنا ABCs, we want to check the glucose. What else? Check pupils. Okay, good. So full physical examination, absolutely لازم, شيء مهم. بس قبل sample history. شوف, الhistory you have to take from every single patient who comes into the emergency department. بس الشيء اللي بتغير هنا انه احتمال يكون البيشنت decreased level of consciousness like you guys mentioned, so they may be in a coma, and if they're in a coma you can't take a history, but you have to do your due diligence and looking at the medical records, asking the ambulance personnel if they came with an ambulance, asking the family members if they came in or not. You try to find out a son, a daughter, a father, a mother, whatever the case may be, and talk to the family and see what they know. And you can also check their if they're wearing any bracelets that tell them that طبعا هذه يعني قليلة جدا عندنا, but it's something worth considering, and it may change in the future. That's something to put at the back of your mind. Check potassium. طيب, we'll do levels, glucocheck or VBG, which shows you electrolytes at a fast time. What else? يعني لو أنا جيتكم الحين إن altered ولا decreased level of consciousness, that's it, that's all you're going to do. Sample history و ABC و that's it. Check glucose. طيب, اتفقنا إن we want to do labs. حلو. What labs do we want to do? We want to do CBC, we want to do VBG or ABG. What else? Imaging if needed. يا جماعة قبل, stepwise approach. So ABCs, glucocheck. You can take, when you're doing a glucocheck, you don't have to actually withdraw labs. But what do you need to do? History. What else? Basics. Yes, shukran. Take the patient's vital signs, put them on a stretcher, have IV lines inserted, take the labs on the side. يعني أنا طالما إني أنا بحط IV, I might as well take labs, take blood, and then I can decide later on what I want to send them for. ليش أحط IV? Just in case I want to give them medication. What if I check the glucocheck and it's low and I want to give them D50? How am I going to give them D50 and they're not awake? So I can't ask them to drink a sugary drink. I have to give it to them IV. So I need an IV. So that's one. What else? Oxygen. Want to do a cardiac monitor. What if this patient's decreased level of consciousness is because of an MI? I need to do an ECG. You can give thiamine or naloxone if you suspect on your physical examination that this is secondary to a thiamine deficiency and or an opioid overdose. What else? What if this was a trauma patient? We want to make sure that they have spinal precautions on, صح? Good. C-spine. طيب. What are the labs that we want to do other than ABG or glucocheck? CBC? What else? I expect to do an absolute full examination, including the peripheral pulses. Good. So you want to do a CBC, you want to do a glucocheck, you want to do a VBG, قلنا, electrolytes. You want to take a urine sample, especially if they're an older patient. You want to make sure that you do urinalysis. If they're a younger patient, you want to take a urine sample to do a urine tox screen. You have to do a drug screen, especially if they're younger. So you have to send for alcohol. You have to send for acetaminophen, aspirin, especially in cases of suspected overdose or patients who come in with suicide attempt, known psychiatric or not. You have to do this imaging as per what the history and the examination tells you. So if you suspect that this is secondary to a trauma, or if the patient has a seizure disorder, or if they have a fever and you're suspecting meningitis, before you do an LP, which is another thing that you might consider doing, a lumbar puncture. Yes, you want to do liver enzymes, ammonia level if the patient's known liver disorder, or you suspect hepatic encephalopathy, thyroid, because if an elderly patient comes in with a decreased level of consciousness, they can have mixed edema coma, which is secondary to hypothyroidism. So that's another thing that we didn't mention in metabolic or endocrine. Back to the case. So قلنا 75-year-old female, found down at home, brought by EMS, no other info at this time. What do you want to do? Ask me and I'll give you the answers. أنا أقول لكم 75-year-old female حقتنا اللي في البداية. She was found down, brought to your emergency department. You have no other information at this time. What would you like to do for this patient? نخليها تموت؟ خلاص عاشت يكفي 75 سنة صح؟ الحمد لله خير وبركة. نرسل لعيالها تعزية.
ABC.
ممتاز. طيب you check her ABC. Airway and breathing, she's spontaneously breathing. She has good air entry bilaterally, no added sounds. She has a positive gag reflex. Her trachea is midline. She has no pooling of secretions. A C, she has a regular rhythm. Her heart rate is 101. She has present femoral pulses. She has present but diminished distal pulses. Her blood pressure is 88/45. Her temperature is 35.6. Her saturation is 92% on room air. Just an FYI, انتم آخر سنة صح؟ انتم بتصيرون interns. بس للمعلومية ترى في الريزيدنسي كل سنة بيسووا لكم practice oral exams regardless of what program you're going to be in. This is how the oral exams are going to be like. You're going to get the information, You have to choose what you want to write down. You have to take action on all the information. طيب maintain her BP. يعني what do you want to do؟ قل لي. يعني أنا أعطي order أقول maintain her BP وخلاص وأمشي وهو spontaneously و magically it gets better. ممتاز. So زي ما قلنا نحطها على monitor, we get an IV line, we send for the labs. What would you like to send for? ما تقدر تعرف أنت you sent for what because you didn't do an examination. So you have to do a complete examination. Listen carefully to the complete examination I'm going to tell you now, okay? So her head and neck, her ear, nose, and throat shows pupils are equal and reactive. Tympanic membranes are clear. Mucous membranes are slightly dry, okay? Her neck examination shows no rigidity, and she has no jugular venous distension. Chest examination shows no crepitus, no signs of trauma, good air entry bilaterally. Cardiovascular, pulses as mentioned, so she has present femoral pulses, present but diminished peripheral pulses, heart rate of 101, blood pressure of 88/45. GI examination shows a non-distended, soft, non-tender abdomen with normal bowel sounds. Rectal examination shows normal tone and present stool with no evidence of blood. Extremities show no injuries and pulses as previously mentioned. Back shows no skin changes, no signs of trauma. Neurological examination is limited, but her cranial nerves, from what you can do, is grossly intact. She withdraws to pain. She has no gross neurological deficits. Her reflexes are symmetrical. She doesn't answer your questions or follow your commands. This is why it's a limited examination. And she is moaning. Her skin is well perfused. Her GU examination shows an atraumatic perineum with no discharge or lesions. What would you like to do now? What was abnormal from what I've mentioned? So she has dry mucous membranes. She has an altered level of consciousness. What else was abnormal? Check glucose. We check the glucose and it's normal glucose. So it's 5.8. What else was abnormal? Peripheral pulses are diminished. حلو. What else was abnormal? ترى توني مسوي لي قهوة ثانية يعني فجالسين لسه. لذيذ القهوة. ممتاز. Blood pressure is low. What else? عبد الرحمن الحربي الله يعافيك. انت حق الحلقة اللي تقول يا فدنا افادكم الله ما ادري نفع الله بكم ما ادري ايش تقول. ايه اوكي كويس. طيب وش الشيء اللي بالاخير اللي قلته ما انتبهت له؟
اتوقع انت سويت منشن على السكن او شيء كذا يلويش، ما انتبهت صراحه، كنت وقتها اكتب في الاجابه.
سكين قلت well perfused. فحنا الى الان انتم قلتوا لي عندها اللو بلاد بريشر، قلتوا لي عندها الديمينشد peripheral pulses، قلتوا لي عندها الميوكس membranes dry، وعندها اللي هو altered level of consciousness. What else is abnormal on the examination that I've mentioned?
اتوقع دكتور هذا كل شيء.
خطأ، هذا مو بكل شيء. لو هذا كل شيء كان خلصنا ورحنا للسلايد اللي بعدها. فيتال ساينز وش فيها؟ الفيتال ساينز قلنا البلاد بريشر 88/45 فقلتوا لي هايبوتنشن. الهارت ريت از 101.
الهارت ريت 101 اي سلايتلي يعني نورمالي الى 100. اتوقع 101 از كايند اوف
75 year old. لو قلت لك ان هذه
لا تكي كارديا دكتور، لانه عندها هايب عندها
90 is abnormal. That's number one. Number two, لو كانت هذه 75-year-old female that you know nothing about is a cardiac patient on a beta blocker. This is absolutely severe tachycardia حتى مو بس tachycardia. Her temperature is 35.6. Is that normal?
لا
ممتاز. It's not normal. هذا الحين احنا مع البلد بريشر والهارت ريت والتمبرتشر دخلنا في سيرز كرايتيريا، صح ولا لا؟ قلنا she doesn't answer cues اللي هو questions or follows commands و she's moaning. Her SpO2 is 92. Depending on what her past medical history is, 92 may not be normal. I'm okay with a patient having a saturation of 92. At this age, I'm fine. As long as they're above 90, I'm okay with it. I don't rush to place a patient on oxygen. Tamam? Especially if the patient's a COPD or a patient is elderly or a patient has heart failure, may have some fluids on their lungs. So it may be. So what else am I going to do? Do we think that the causes of her status now is focal or global? Focal meaning a specific thing affecting the reticular activating system, ولا global meaning affecting both hemispheres. لأن قلنا if it's an altered mental status or decreased level of consciousness, it has to be one of these two. So do we think it's focal or global? I agree. We think it's global. شكرا فيصل. طيب. Summarize. I want someone to summarize the patient's status based on the physical exam and the information that we've mentioned. And then based on that, give me a differential diagnosis as to what could cause her status. حتى إذا مستحيل تتكلمون بالمايك اكتبوا عادي. الزهايمرز ديمنشيا صعبة انها تعطيك تاكيكارديا وهايبوتنشن و diminished peripheral pulses يعني في multiple issues going on. I wouldn't say that this is just dementia. Dehydration as a secondary cause of what the major thing that's going on is, yes. ابغى منكم 5 differential diagnosis.
دكتور اجاوب؟
ايه تفضل.
ممكن يكون infection.
ممكن يكون infection. Give me specific infection.
زي مثلا appendicitis بس لا بالعمر الكبير kind of يعني unlikely.
ممكن يكون بس lower on my list. What else?
في الانفكشن ولا في الاذر؟
Diagnosis, whatever you think, whether infection or not.
ممكن يكون دايريا سوت severe dehydration وزاد عندنا
So infectious gastroenteritis. Okay, so gastroenteritis and appendicitis. These would be in مثلا number 10 and 11 on my list. قبلها وش أحط؟ UTI. This would be number 1, maybe number 2 on my list. What else?
بس دكتور UTI ما تسوي representation على الديهايدريشن على الهايبوتنشن.
Can UTI lead to septic shock ولا لا؟
اي.
طيب that's your answer. If you have SIRS criteria positive, plus a potential source of infection, it can give you hypotension or tachycardia. Is she febrile?
She's اللي هو يسمونه lower
طيب.
temperature.
Hypothermia is one of the
Hypo.
SIRS. So yes, it could be an infection. You don't necessarily have to have fever. You can have hypothermia as a part of a SIRS criteria. طيب, what else? قلنا الحين UTI, هذا one of the bigger ones. What else? بزعل عليكم. Pneumonia, what else? Could be a skin infection. What else? Other than infections, what could be going on? يعني صعب انك تسوي diagnosis ال 75 year old بأس اللي يعني مرة متأخر. غيرها يا جماعة تونا قايلين move stupid. Based on the information of the patient, what is likely from the move stupid mnemonic as a cause for her symptoms, her presentation? MI ممتاز. حتى لو كانت MI, it could be a major, يعني it could be a primary cause for her symptoms. It could be a secondary cause لو كان عندها infectious process بعدين صار عندها demand ischemia. فتكنيكلي ما تصير ACS بس تصير infarct because of demand ischemia. What else? Organ failure is not a diagnosis. ممكن كان عندها hypoglycemia and she fell and hit her head and she has a CVA. ممكن كان عندها CVA and she fell and hit her head. ممكن يصير عندها لا, COPD is definitely not a diagnosis in this one, not even to consider. Could it be mixed edema coma from hypothyroidism? Could it be serotonin syndrome? Could it be secondary to her drugs? These can all cause these. Ulcers, I'm not sure if يعني قلنا skin examination is normal, unlikely to cause this. طيب, you've sent for her labs. You guys are just throwing out diagnoses وتقولون لي هذه المشكلة ولا واحدة مثل لا COPD ولا ulcers ولا cancer اللي كان maybe secondary mets للبرين هي اللي قلناها. عندنا these are her labs. What do we think based on this? So we have a 14.5 white count. Hemoglobin is 14.5 as well. Platelets is 380. BUN is 14. Creatinine is 110. Sodium is 141. Potassium is 4. Chloride is 101. LFT is normal. Coag is normal. Aspirin, acetaminophen, normal. She has a normal glucose. So no, she doesn't have DKA. And she has what's going on with her urine. So yes, she has leukocytosis. What else? Yes, absolutely. We think that the most likely diagnosis is UTI because she has leukocytosis with bacteria. WBC is nitrate and Lucas 3 is positive. In addition to her presenting with a temperature of 35.6, tachycardia, and hypotension. So how are we going to treat this patient? . Antibiotics only. Yes, IV fluids, because you guys mentioned she had dry mucous membranes, she's tachycardic and hypotensive, so she needs fluids and she needs antibiotics. The earlier, the better, and the less complications. So the less likelihood of having morbidity and mortality. So now we know it's a UTI, we'll treat as a UTI. Is this enough to explain the patient's symptoms? I think so. I think it's enough to explain the patient's symptoms. I think if a patient presented to me with these symptoms and then has evidence of a UTI, I would call it sepsis or septic shock and I would treat. Do we stop the workup in a patient her age? لا خلينا من check every day. خلينا من check every day CBC. الحين اتكلم انا على اساس انك في الامرجنسي ديبارتمنت you have this as an explanation. خلاص نوقف كل شيء بس نعطيه فلود وانتبيوتكس وانتهى الموضوع. We sent for a culture, absolutely. So blood culture and urine culture. Want to make sure that she doesn't have a UTI, a bacteremia as well with the UTI. But do we stop the workup? What else can we do in this patient with her presentation and her age? I would not discharge this patient under any condition. This patient, if she came to my emergency department, should be admitted for urosepsis in the emergency department. But what else as a part of the workup should I do?
دكتور يمكن بعد الفلويد نسوي تشيك على الكرياتينين ليفل عشان نتاكد انه ما عنده رينال فيلير.
بس what else would you do؟ يعني انتم لا تنسون انكم قلتوا ان البيشنت came in with tachycardia, hypotension, temperature of 35.6, mucous membranes are dry, she has a decreased level of consciousness, she has a decreased level of consciousness, and she has diminished peripheral pulses. You've given antibiotics and you've given fluids. Yes, I agree. We have to do a CT head. We have to do an ECG to make sure that she doesn't have a cardiac process going on. What else? One big thing that's missing. So if this patient came to my emergency department, I would still do a CT head and I would do an ECG. What else? I would do troponin levels to make sure that she doesn't have demand ischemia or a primary or even secondary cardiac event. But what else? One big thing. I would do a chest X-ray, Jama'ah. Make sure that she doesn't have a concomitant infection. We know she has an infection, but it may not be only a UTI. It could be a pulmonary infection as well. You guys mentioned this before, that she could have a pneumonia. So we have to make sure that she doesn't have a pneumonia as well. What else should we consider? We can consider a urine drug screen, and we can consider an LP if we have concerns that she has an intracranial process going on. But in this patient, I wouldn't necessarily do that. Okay. طيب. So we did the EKG, it was normal, chest X-ray is normal, CT head, our brain is normal. LP, I wouldn't have done it, but let's say we did it normal, and she did the urine drug screen and it was normal. So what do we do in this case? في أحد قال referral to ICU. It depends on her response to fluids. So if she responds to fluids well and her blood pressure and heart rate improve, she can go to the floor. If not, then yes, I agree. She would go to the ICU and consider, if not improving, with a fluid bolus, starting her on a vasopressor such as norepinephrine. What's the thing to remember about this is always reassess, like you guys mentioned. So monitor her vital signs, ensure no changes are happening, whether it's with labs or vital signs, and ensure that there are no other causes of symptoms, which is why we did the ECG, why we did the chest X-ray, why we did the CT head, why we considered doing the LP and or the urine drug screen. These are all things to consider. The conclusion with this is that basically altered level of consciousness or altered mental status, you have to maintain a broad differential because you could have one cause that's difficult to find or multiple causes happening at the same time. You could have the diagnosis through clue finding, but you have to actually put in the work, such as with this patient, you have to call family members, you have to call if she came from a nursing home or a rehab home, you have to call them and ask what her situation was. We have to focus on whether it's a focal and the reticular activating system or global in both hemispheres. And then we have to constantly reevaluate the patients. Before we move on to a couple of more cases, just to see how you guys do with them, do you have any questions? No questions? طيب I'll give you another case. اللي بيكتب يكتب، اللي ما يبي يكتب كيفه، بس عشان ما تسألوني على ال vital signs. So you have a لحظة بس خلينا نسوي stop share screen عشان خلصنا منها. أنا موجود ولا لا؟ أوكي أنا موجود. طيب you have let's خلينا بس اختار لكم age كويس عشان نجيب لكم الفايتلز بعد كويسة نشوف ايش تسوون فيها. give me 1 second خلينا نفتح الفايل حق الكيسز. طيب you have a 47-year-old man who comes into your emergency department, has a significant history for hypertension, hyperlipidemia, and diabetes. Comes in with a brief episode of chest pain. While examining the patient, he develops an episode of slurred speech and right-sided weakness. His blood pressure is 146/92. His heart rate is 91. His respiratory rate is 18 per minute, and his saturation is 99% on room air. His temperature is 37. So what would you do for this patient? ABCs first. ممتاز. What else? اصبر وين رحتوا انتم؟ لحظة اختفى. دقيقة ما اقدر. وينكم؟ اوكي لقيتكم. طيب developed brain stroke, ABCDE, ECG, chest X-ray ممتاز. ECG, CT head ممتاز. vital signs قلناها. مو vital sync يا معتز. طيب CT of the head. طيب what's an important thing that we discussed before that you actually have to do before any of this, other than the vital signs and the ECG? I agree, especially that they have an episode of chest pain. Shukran. Glucose, check glucose, because this could be just an episode of hypoglycemia, such as the patient that I had in my emergency department. Okay, so we have to make sure that that we actually take that into consideration. So you check the glucose, and the glucose for this patient is 1. What do you do? الجلوكوز حقه 1 يا جماعه، قاعد اتفرج عليه. اي دي 50. شكرا. Okay, good. So let's take another case. You have a 27-year-old female without significant medical history who comes into your emergency department unable to speak for the past 90 minutes. How would you approach this patient? طيب, you check her ABCs, and her airway, breathing, and circulation are all fine. She has normal vital signs, but she won't speak to you.
ممكن اخذ بشوف
ما اسمع. ممكن تشرح لي يا علي ليش chest x-ray؟ نوح. Yes, I would talk.
دكتور تسأل.
اي chest x-ray ليش؟
دكتور نسوي physical examination، نسوي ونسأل الشخص اللي بيكون معاه.
اوكي ممتاز. So you take a full history زي ما
يمكن
قلنا.
عنده نيموثوركس يا دكتور.
نعم.
نيموثوركس.
pneumothorax بيخلي البيشنت unable to speak.
Or عنده airway obstruction.
اوكي ممكن، بس the patient's normal vitals، يعني صعب انك تلقى واحد عنده airway obstruction just sitting there unable to speak او with normal vital signs. So always the approach is ABC. وقلت لك ال ABC is fine. تمام. You have to take vital signs. Vital signs are normal. She just can't speak to you. She won't speak. ساكتة. And these are patients that we actually see in the emergency department. So you take a history. I like the approach is talk to the family. So you talk to the family. They tell you that when this happened, she was on the phone and received news that her friend passed away in a car accident. And then afterwards, she never spoke. ما أتوقع أنها pain attack. She doesn't have any pain. ولا حتى panic attack. Panic attack is usually, it's defined as a impending sense of doom. So typically they're breathing fast. They feel like they're going to die for one reason or another. So yeah, this is conversion disorder. So basically it's a psychiatric thing. Typically you basically cognitive behavioral therapy, and you talk to them. It's not necessarily shock. انتبه يا فيصل متى تستخدم كلمة shock، لأنه كلمة shock غالبا تعني إنه the patient has hypotension, is tachycardic, they're not responding to fluids, they need vasopressors and so on. Post-traumatic stress disorder is also يعني it has its own diagnostic criteria. So this is basically conversion disorder. Some people go mute, which means like this patient, they don't speak. Some people have neurological symptoms where they can't move a limb, they can't move a leg, they say that they can't see anymore, they're blind. Does this mean that that's the only considered diagnosis? Absolutely not. You have to work on other potential diagnoses and see what's going on. One more case. So you have a 25-year-old male who comes into your emergency department, unconscious. He was brought in by friends. طيب, you check the patient's airway, breathing, and circulation. The patient's airway is intact. There are no signs of obstruction. Breathing, he's breathing spontaneously at a rate of 16 per minute. His saturation is 99% on room air. His vital signs, his circulation. طيب, heart rate is 110. His blood pressure is 100/55. His temperature is 36.8. And vitals قلناها خلصنا. You ask them what happened. So they say that he called them and he had slurred speech, and they went to pick him up and they found him unconscious. No evidence of trauma on physical examination. That's all you have. What would you like to do other than ABC's vitals, which I already gave you? طيب, urine drug test is sent. What else? You check the pupils. Pupils are equal and reactive at 1.5 millimeters. Okay, so we do an ECG. The ECG shows sinus tachycardia with no concerning abnormalities at 110 beats per minute. LP is very aggressive من البداية يعني. Okay, glucose level is normal. He's not speaking to you. He's asleep basically. He's unconscious. طيب, اللي يبغى glucose قلنا normal. You want to do a CT, you do a CT brain and it comes back normal. What's a potential diagnosis and what are you going to do to help yourself diagnose this? شكرا فيصل. MRI ليش؟ سويت CT وما في شيء، وش بيطلع لك الMRI؟ يعني صعبة كل بيشنت يجيك الامرجنسي ديبارتمنت تسوي له CT ما يصير فيه شيء تسوي له MRI. Could be a stroke in a 25-year-old, but his CT is negative and he is unconscious. What kind of stroke makes you unconscious? Thank you very much. Alcohol. And a young 25-year-old who was previously normal, talked to their friends, he had slurred speech, راحوا له لقوه نايم. غالبا he had something to drink. It could be ethanol. و a special consideration زي ما شفتوا في الأخبار قبل يمكن شهر أو شهر ونص. لما كان في a bad batch of alcohol going on, which was methanol. So always consider also toxic alcohol. So methanol and ethylene glycol are things to consider. طيب هل في أي أحد عنده أي سؤال؟ أتمنى أن كانت واضحة. The reason why it was super annoying probably for you إني أحاول أسحب منكم المعلومات is I really want you to learn and it's supposed to be a session يعني an interactive session rather than an actual lecture. I hope you enjoyed it. I hope you actually came يعني that you came out of this with some new useful information. You're more than welcome to ask me at any question anytime. Or if you have any questions later on موجود الايميل حقي الحين احط لكم اياه في الشات. الله يعافيكم. Any questions? كيف تعرف إذا تسمم؟ إذا كان ميثانول أو toxic alcohol. يعني في الميثانول has its specific signs والtoxic alcohol has its specific sorry الethylene glycol has its specific signs. الميثانول which is more common دائما يصير فيه depressed level of consciousness يعني النورمال alcohol intoxication يصير improves with time. Toxic alcohols they get worse with time. Methanol causes blindness, causes brain edema, can cause brain bleeds as well, and can cause kidney failure. Ethylene glycol as well. بس طبعا في تفاصيل تقدر تفرق بينهم. I won't get into the details of. The best way is, if you're concerned about the toxic alcohol, is to send for a toxic alcohol screening. So they send for methanol and ethylene glycol levels. Any other questions? Panic attack can lead to unconsciousness if they breathe fast for too long. It can lead to unconsciousness. This is why we ask them to breathe in a bag, because if they breathe in a bag, then they get a return. So they're breathing their own CO2, or CO2 leads to vasodilation. Vasodilation leads to relaxation. Any other questions? الله يحفظكم. يلا بالتوفيق جميعا. في أمان الله.